Labi, kamēr jūs reģistrējaties, es bišķiņ izstāstīšu. Tātad, cik ir tie, kas bija konferencē? Bija konferencē? Viena, one was on the conference.
Yes. Oh, yeah,
She
yeah.
knows everything.
Okay, very good. You can go to sleep.
Lūdzu? Jā, jā. Nu, tas jau tāpat, jūs jau to pašu dzirdējāt. Mēs tur klātienē neko citu nedarījām. Labi, tātad bērnu slimnīca šogad realizē projektu, jau gadu realizē projektu asinsvadu komandu bērnu slimnīcā. Viņa tika izveidota pilotprojektu ietvaros ar NVD finansējumu un uzsākot šo projektu. Mums nebija tāds plāns organizēt apmācības, bet tā kā mēs organizējām apmācības mūsu ekspertu komandai un ik pa laikam mēs ar jums draudzējamies gan ārsti, gan māsas, tad daļa nokļuva arī jūsējie, un tā tas viss aizsākās, ka mēs sapratām, ka mums ir jādalās. Un tad otra lieta, tad, kad Denis piekrita, ka viņš ir brauks pie mums uz 2 nedēļām uz Latviju veikt apmācības, tad arī man likās, ka es nevaru paturēt viņu 2 nedēļas tikai bērnu slimnīcā. Tā kā piedodiet, es esmu laimīga, ka jūs šeit esat. Denis noteikti paprasīs, vai jūs piespiedu atnākt, vai jūs paši atnācāt. Tātad šī ir tā iespēja, kā jūs varat uzzināt no paša eksperta kaut kādus iespējams jaunumus. Uzreiz pasaku, pēc 2 stundu apmācībām ultrasonogrāfijas certifikātus neizsniedzam. Pirmkārt, tāpēc, ka tas nav legāli Latvijā, mums vēl joprojām nav atļauts to darīt, bet tā kā mani kolēģi saka, nav arī tā, ka pilnībā aizliegt. Tāpēc mēs tomēr klusiņām jums šo staciju pamācīsim. Un arī pārējās lietas jūs redzēsiet ļoti īsi, jums būs ieskats un būs daudz mājas darbi, jo visas tās lietas jums būs mājās pašiem nodaļās jāmēģina un jāizdara. Tā kā es aicinātu tos, kas klausīsies gan uz pirmo reizi nākt tuvāk. Lekcija būs tikai angļu valodā. Kaut ko varēšu patulkot, bet ja mēs tulkosim, tad mēs pazaudēsim ļoti daudz laika. Lielākā vērtība būs pēc tam to visu viņi izstāstīt, to iedzīvināt dzīvē, tā kā visu izmēģināt. Tāpēc arī, Denis, now it's your turn, so okay. They know they will not get certificates and they know that this is just the introduction, not the whole story.
Yes. Okay, good. All right, so for those of you here, no, keep these on for now, yeah. I don't want to fall asleep. All right, so how many years have you been flushing with the syringe? With your fingers, let me know. 3 years? 4 years? 20 years? 23? 2? 3? How many years? Huh? 15? Okay, 15. How many? 10? How many years have you been walking? Don't answer that one. Okay. We've been walking for many, many, many years, right? I've been walking for 38 years. No, 36 years. Not from 0. 30, I don't remember. 36, 34 years, right? So how many of you took a class on how to walk better? What? You don't take classes on how to improve walking, but there are things that we've been doing that may be better. Have you heard of the phrase, why change something that's not broken? Have you heard of that before? Why change what's not broken? It's because we don't know it's broken. We don't know, we didn't know. So is this normal? No, when I walk, I should be walking normal. But if I trip and everybody trips, it's normal. We don't think about it. So what I'm trying to show you guys, and this is not it's instructional. It's not to tell you what I think you should do. This is to discover what can you do. Because every situation for what I'm recommending and what I'm showing may not apply to your situation at the moment. It's still your decision. It's still your critical thinking to decide, is this a good idea or is this a bad idea? Does that make sense? So I'm not telling you what's better, maybe, but I'm telling you what's possible. All right, so let's go into it. Flushing complications. Here are the issues: high pressure, pulsatile versus laminar. How many of you flush like this? Boom, 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 boom. Push, pause, push, pause, push, pause. Do you guys do that? Do you remember when you did just 1, 3, right? So Pulsatile versus laminar, which one is correct? I will show you what my opinion is on that. Catheter extravasation and blood reflux. Catheter extravasation is the catheter coming out of the vein. Why does that happen? We're going to find out. Okay, so here we go. Low pressure to laminar PIV is what I think is best, and pulsatile for CVC. So anybody work with central line catheters? Internal jugular, subclavian, PICC line. So for CVC, pulsatile definitely good. For PIVs, I like to do gentle laminar, very smooth for peripheral, and I'll explain why. Adequate vein purchase. I need enough catheter in my vein. If I have this much in my vein, is this going to come out? Maybe, more likely. What if I had this much in the vein? Is it coming out? Very difficult. Okay, so you want enough catheter in the vein, and we'll talk about that as well. High pressure is an issue. Anybody know Virchow's triad? Anybody know? Do you remember from school? I don't know if they taught you. Virchow discovered a long time ago there's three main problems with thrombosis. Three things that cause clotting. It's stasis of blood. So when blood slows down, blood should be moving pretty fast, right? But if blood slows down, it's going to cause a clot. We know this. If a blood stops, it's going to start creating a clot, right? What about for endothelial injury? If we pop or injure or scratch or rip the vein, there's going to be clotting. If the patient's disease causes the clots, that's possible as well. So we're going to talk about endothelial injury. Please say yes. Did you know there was blood inside of the vein? Yes. Okay, good. Did you know that there was a vein cell called the endothelium? Do you guys call it the endothelium? No? Do you know the inside of the vein is called the endothelium? It's the endothelial cells. Did you know that there's something in between it? It's not just blood and then vein. It's blood, glycocalyx, protein, and then vein. There's something in between. The glycocalyx protein protects the vein from the blood. The blood has clotting factors, factor 1, 2, 3, 4, 5. You guys know this? What about inflammation factors, white blood cells? The glycocalyx protein protects the walls from those things. This is what's in between. If this gets damaged, your clotting starts. If this gets damaged, your vein starts to have inflammation. So this is the important protein. Don't worry about the definition. It is important, but not for you to fully understand just yet. What happened to his skin? Damaged. Is this a knife? No, it's not a knife. What is it? Yes, it's water. I drink water. Is this cutting my throat? Is this cutting my mouth? No. But with enough pressure, you're going to break things. You're going to cut things with water. That's same thing with your saline, and I'm going to explain why. How many of you flush adenosine before? It's an emergency medicine. No? Okay. When we flush too hard, does my vein go this way or does my vein go this way? What happens to my vein when I flush really hard? It gets bigger. We increase pressure, right? Wrong. But thanks for playing. Yes, most of us, everybody thought it gets bigger. Anybody else think it got smaller? I didn't. When I remember, I learned this 3 years ago. That's it. And I've been doing this since 2012. A few years, and I just found out about this. This is what happens when you flush too hard.
Clotting because the endothelium is being damaged by how...
Is it expanding or is the vein collapsing? What's happening?
And as you can see, there's a little bit of damage. That cement gets degraded.
That's the catheter. And when I flush hard, what's happening to the vein?
When you damage damage the endothelial lining of your vessels.
Is it expanding?
Develop clots because your body's
No,
trying to heal.
it's closing, it's collapsing, okay? So
When you clot, your line stops working.
this is what's happening. Now, this is a real immediate reaction to hard flush. So there's my catheter. Can you see that okay? This is my vein.
It's like from here at baseline.
Okay, I flush hard, and then it closed.
This is me slamming the flush. I'm going to measure to see if there's any gas in. Right here. That's from slamming it like I used to in the ER. There we go. We'll compare this
Look at the difference
for
of the lumen size.
it all from the.
What happened immediately, not 3 minutes later, not 3 hours later, not 3 days later, immediately the vein spasmed. It got angry, it got mad. So the body's reacting to our flushing and we have to be very careful. So shear force, it's not, let's say scratching. I wish I knew the Latvian word for it. Shear force is increased friction. Okay. When we increase pressure, we increase friction. When we increase turbulence, is there a word in Latvian for turbulence?
The same word.
Same word. So in turbulence, we also increase friction. This is the study. Okay, I'm not expecting you to go memorize this. However, this opened my eyes to if your catheter is resting higher, your catheter will fail faster. If you're pushing harder, your catheter will fail sooner. How many days on average do your IVs last, your peripherals? Give me with the fingers. 1 day, 3 days, 4 days, 10 days, 20 days. For you, 3 days. About 3, 7? 72 hours, okay. So just a couple days. Anybody else?
5 days.
4 days, that's average. So this is found that the higher your catheter resting and harder, your catheter dwell will be less than that. The harder you flush, the less it'll stay in there. This is a study. Look, I know we're not here to do math. I promise you, this is just proof. That's it. I don't expect you to understand this fully just yet. All right, catheter extravasation. This is also a key component. How do you know that the catheter is out? How do you know? How do you know the catheter is not in the vein? Not good? No blood. No blood return. Yes, very good. Anybody else? What about when you flush? How do you know it's not in the vein? What happens when you flush? Huh? It doesn't work. But what happens to the skin? What do you see? Right? So it goes out, it starts to swell. What do we call that? In the US, we call that the IV blew up or the IV blew. We say that, it blows up, right? So you just saw in the video that when you flush, it doesn't expand. It collapses. So then how is it blowing up? Is the vein rupturing? No. The catheter is coming out and we're filling the subcutaneous space with fluid. That's usually what's happening. So we need enough of the catheter in the vein. And to do that, it depends on technique, but also you need a long enough catheter. Has anybody seen a catheter this long? This is long. This is the longest catheter in the world for PIV that I've seen with the needle size. Okay, so you need something longer. Maybe we need to get longer catheters for your patients. All right, adequate vein purchase is key. This is what happens. Guess what medication this is? Tell me, what do you think? Huh? Calcium? Very good guess. Calcium will necrose the tissue. Not this time, but it could be, yeah. What did you say? Antibiotic. Okay, yes. Vancomycin. So vancomycin killed all this tissue. Do you know what the patient was told? The patient told the nurse, hey, it kind of hurts, it burns a little bit. And the nurse said, oh, no, it's normal. It's vancomycin. It's okay. It happens. When she flushed, it was fine. It flushed okay. And then she said, hey, it's starting to swell a little bit. And the nurse flushed it. She said, no, it's fine. It flushes. It's okay. It's normal. And then it got so bad that it was red and very hot. And the nurse still said, oh, it flushes. It's okay. So what was happening was, even though the catheter was in the vein, the inflammation from the chemical irritating the vein caused the veins to become more porous. That means that the medication was leaking outside of the veins. When the vein has inflammation, it becomes more open, meaning more chemicals will come in and out. That's why our patients swell. So it's not normal when it hurts. When it hurts, there's a problem. We have to address it, okay? What's this? Don't worry, I don't expect you to guess. It's soda, bicarb, okay? Emergency medication. We had to cut off his arm. Blister, okay, so when we go to the beach and we lay down, anybody go to the beach? Right, okay. So when we go to the beach and we lay down for too long, too much time, and we see a little blister, right? Sunburn. Do you go to the hospital? No, you're nurses. You pop it and then you put a Band-Aid. That's it. You don't go to the hospital. Come on, it's not that serious. But for extravasations, understand, with the sunburn, the skin is the first tissue to be damaged. The first one. But for extravasation, listen carefully, it's the last tissue. The last thing to be damaged. What's under our skin? There's muscle, nerve bundles, nerves, arteries, lymph vessels, muscle, fascia, bone. There's lots of many tissues. They have all been damaged already. If there's a blister, the skin was the last thing to be damaged. It's very, very bad when there's a blister. You must address it very quickly. Unfortunately, bicarb has no antidote. So we had to cut off his arm, okay? All right, so this is what happens with babies. When it's extravasated, we're not paying attention, our patients suffer.
By most CT protocols to deliver the desired image quality. Extravasation is an
Look what happens with the catheter. Have you guys seen this before?
catheter placement, catheter movement inside the vessel, unhealthy vein condition, or even the impact of contrast on the vessel at high flow rate.
That's what happens when we infuse too hard, too quickly. Look at that. That's water. That's not wood. That's not metal. That's water.
Extravasation is an undesirable complication.
So,
Catheter placement.
if water can push a human body, what is it going to do to this little thing? I wish I had emergency people. When I send people, wait, there's no CAT scan here, right? Is there a CAT scan here? CT scan?
Is this hospital?
Yeah.
Or it's multiple?
Okay, good. Has anybody sent their patient to CT scan? Yeah? What happens to the IV when they come back? It stops working, right? Why? Because of this. It's pushing it out. Whose fault was it? Was it CT's fault or was it our fault? Who put in the catheter? We put in the catheter. But we didn't know. That's what I'm saying. We didn't know that tripping was bad. What I'm trying to show you is there's options to improve practice for our patients. So we're going to go over how to improve it. This is one way to improve it. This study showed the ultrasound. Who said 4 days? You said 3 days or 4 days?
3.
You said 3. Who said 4 days? 3, 4. Wouldn't it be nice if your patient's IV lasted 8 days? Why? Don't you like putting in IVs? Yes! It feels so good when you get it in, especially when it was difficult. Yes! That's why I got into this specialty. That's why I got into vascular access. Yes. So, the ultrasound, this study showed that ultrasound usage with this catheter, 8 days, 6 days, it doubled the dwell time. So it's something about the way we're putting it in that made it better. Now, if I use ultrasound, is it guaranteed I'm going to get it every time, or guaranteed it's going to last a long time? No, it's just a machine. It's me who still moves the needle. It's still me who controls what I do to the patient. So it's us, it's a skill. That's kind of where I want us to get to. There's skills, and I'm hoping to open your eyes a little bit to different ideas. Pulsatile versus laminar. I think, and this is strictly opinion right now, because there's new studies still being formulated. I think pulsatile for central lines, so PIC, CVC, and then FIC, femorals, all should be done with pulsatile. PIVs should be done with laminar and gentle. One slow push. I'll explain. Why do we do pulsatile? It's because we want that turbulence to scratch the inside of the catheter. But what happens right outside the catheter? The vein also gets scratched. So we also have to be careful with that. Now, with central venous catheter, it doesn't matter because it's so big and there's so much flow rate. Your flushing is not going to cause much shearing. All right, so this is what happens if you flush too hard. Check it out. That's a PIC catheter, 4 French. This can still happen with your CVCs. You can push so hard that you move the catheter from inside of the body.
Almost there, but it hasn't dropped yet.
See how much it moved all the way down because of that pistoning. So be careful not to flush too hard. All right, so why laminar flushing? Because it reduces shear force. We talked about this. This is the study. I don't have to go over this. This is the physics principles. Don't have to go too deep if you want to. All right, now here we go. This is the fun part. Small, large. Which syringe is easier to output more pressure? Let me know. Small. Oh, you guys are so confident that you said it. Okay, I love it. I love it. Now, which syringe, small, of course we know smaller does more. So which syringe is it easier to output less pressure? Small or big? Which one? Big? Oh, both. That is better answer than my answer. I like it. It is both, but it's also 3. I'll explain. Absolutely correct. It's both because it's us. However, it is easier, and you're going to find out. We're going to test everything today. You're going to see it. You're going to feel it. That pushing a little bit is much easier with the thinner syringe. Does your hospital policy say don't use a skinny 3 cc for flushing? Did they say don't do that? Only use 10? Is that your policy? No, use anything. Okay. Okay, good. So good. So it is not the syringe, it's us. But if you want to achieve very low and very high, the skinnier syringes will help you, make it easier. All right, this is the equation, Poiseuille's law. This is the physics principle where I derive everything I'm talking about, okay? I know we're not going to do the math hard, okay? Just real quick, understand that the 3 milliliter, when we see it, it's so small. It's so cute. It's the little baby brother of the syringe, right? The little baby syringe. It's not. It's a monster, okay? It can destroy and blow up a catheter if you push hard enough with the 3 cc syringe. And you can also pull with less hemolyzed blood with the 3 cc syringe. It's easier, okay? So that's why, power of 4, this is how we should look at it. The 3 cc syringe can do more, and the 10 can do less. However, you also have to consider volume. Is it reasonable to try to pull 20 milliliters of blood with a 3 milliliter syringe? I use the 10 because it's easier, right? Now, depending on how difficult it is to draw it, you can choose which device you use. But this is the most important thing. I'm not going to go into the physics of Q, but Q is technically flow rate, but that's us. We control how bad it gets, not the syringe. The syringe helps us, but it's ultimately us. All right, so this is the graph. This is what happens.
100.
Okay, who cares? What's 168? What does that mean? It's just numbers. What is this picture of? Anybody know? Is this cake? Huh? Tire. Yeah, it's a wheel, it's a tire. What does it say the recommended maximum is? It's 51.
This is a 360.
What did I do?
100.
Now there's some context, okay? There's some comparison. This is a tire exploding at 170.
This is a 360 syringe.
What did I do?
1.
Okay, 168. This is a car tire exploding at 170. What did I do? What can I do?
1.
Okay. Am I saying if you flush, you're going to blow up the arm like a tire? No. There's a difference between volume of a tire and volume of a syringe when it comes to energy. However, I want you to realize it's the same pressure. So even with the little volume, we can still do some significant damage. And so we need to be mindful of that. All right. So this is it. We've drawn blood. Anybody draw blood from an IV catheter? Or just needle? Only needle, but or also catheter?
But the first time.
Only the first time? Is that a rule?
No, it's not a rule we do.
Okay. Is it a rule here not to draw blood from this IV? Why?
She don't even know what to tell you.
That's fine. No. Most people, even your policy makers, don't know. Here's why. When you hemolyze blood, it costs a lot of money, especially when you do it many, many times. So I think they found out that drawing from an IV has so many hemolyzed samples, just don't do it. Only do it the first time. Did this change inside of the body? Does this turn into a cat? I know that's so ridiculous, it doesn't even translate. Did it turn into a needle inside the body? No, it stayed the same. So what happened? We're going to find out. I think that you can draw blood if the environment is good. Sometimes it's not. But I'm going to show you what's going to help to reduce that hemolysis. Low pressure, pull, pause, pull, pause, pull, pause. Why should we pause if it's coming out? Have you ever pulled and you're like, oh, it's so good, and then it stops? Has that happened to you before? Why? Why is it stopping? Huh? Yes. Okay, so let's talk about pressure. When you have a small catheter in a large vein, lots of blood. When you have a large catheter in tiny vein, in a small vein, not a lot of blood. So what's happening is you're closing it because there's not enough blood. So what do you have to do? Wait for the blood to fill back up. Wait for the blood to fill back up and then draw a little bit more and then wait for it to fill back up. Or just pull so slowly that it can fill and outpace that pressure. Okay, very good. Yes, pressure. So, cavitation is the wrong word. I made a mistake. It's called barotrauma. Cavitation is a different phenomenon, although they are in the same environment. Okay, so hemolysis. Okay, this is my favorite thing. My favorite thing to say. It seems to me all the nurses in Latvia have the same issue when I talk to them. In fact, I find that all the nurses in the world have the same problem with this issue. In fact, I found out that nurses all over our solar system has the same problem. In fact, all the same nurses in the universe have the same problem. When we send the blood to lab, and lab calls us and say, hey, I'm sorry, it's hemolyzed. It's your fault. We blame it on the lab. We say it's lab's fault, not my fault. It couldn't be me, but it is our fault. We cause the hemolysis before it gets to lab. Yes, of course, laboratory can drop the blood and ruin it, but mostly it happens before it gets up. Mostly from negative pressure. Let me talk about that. So this is cavitation, but it's actually barotrauma that's happening.
Pressure wire that is hemolyzed. So I'm going to
Look.
suction that with negative pressure. Pull on that.
What's happening to the bubbles?
Look what happens to the bubbles. They expand and then collapse. Expand.
Look at that.
Get bigger and smaller.
Did you see how big and small it got?
I know
Okay.
the bubbles, but this is also what's happening in our blood cells, to our blood.
Look at that. Look at how big it got. Okay, so if the bubbles are getting big, what else is getting big? If the bubbles are stretching, what else is stretching? Our red blood cells. Our red blood cells are stretching because of the negative pressure. Now, the blood is like, and it ruptures, it hemolyzes, it lyses the cells when we pull too hard on the blood cells. This is the theory. So when you pull with negative pressure with the syringe or the vacuum tender, you must be as gentle as possible, okay? In fact, this is our normal pressure. 1.5 to 2.3 in the artery is the normal PSI pressure. So if we take it out of our blood from that pressure, what happens to that pressure? It's in a low pressure environment. 1.5 is in our body. Do you guys hear blood pressure? Have you heard of blood pressure? Yeah? Of course, of course. So our blood is in pressure all the time. So when we take it out of our blood, it now goes from normal hemostasis 1.5 to 2.3 to 0. That means when good, it's great. I leave it, I go get lunch, I talk to my friends, I drink some water, and then, oh yeah, that's right. And then now you send it to lab. All that time, it was pulling and hemolyzing that sample. So time is also a factor. So when it leaves the body, you must send it to lab as quickly as possible. Okay. All right. So here's the math. Don't worry about that. Amount of time. So time and pressure causes the hemolysis sample. All right. So this is what we need to remember.
See what kind of negative pressure it applies.
So that's the tube. It's about -4.
So we got to about -4. Now let's see what happens when we pull it with a 3 cc syringe.
And you're going to test this today. You're going to see it for yourself.
At that. Now let's try with the 10 cc syringe. -13. And then we had different PSI.
So we are causing a lot of negative pressure when we pull as hard as we can. Do we always have to pull hard? No. We can pull gently. All right, let's keep it moving. ANTT, anybody change dressing changes? Anybody do dressing changes for central lines like IJ and, okay, good.
After preparing the skin with a skin protectant prep pad, fix the CVC with a sutureless secure device.
Can you clean underneath with this? Can you clean under? Can you clean under the catheter? Yeah, of course. Can you do it when you suture?
Yes.
You can. How? Because you can't take out the suture. Is there a secret you don't want to tell us? I'm just kidding. No, you know what I do? Let me tell you. Everything I showed you that is incorrect, I've done it all. I've done every single one of these. So, this is important. When the doctors suture, when the physicians suture, here's what happens. This is the skin, right? And suture, this will never happen. Oh, it can if they pull it hard enough. Oops. So, but let's say sutured really well. This is not going to move. I agree. You know what I do? I move the skin clean and then put the skin back in. You know when you use the chlorhexidine to clean, I push the skin down, go under the catheter, and then push the skin back up. So instead of moving the catheter, I move the skin in and out. And that's going to cause the infection. Here's another thing. I had an ICU nurse tell me that when she saw 10 centimeters outside of a PICC line, she pushed it all back in. Yeah. That is dirty. That's so dirty. But we do it because we don't know the implications. How many times have I, when I saw it come out 3, I was like, oh. I push it back in. This is an issue that we need to be mindful of. Okay. All right. So sutures, of course, don't work. And I've been speaking to physicians about this. Yes, use it if you need to. However, it's not 100% foolproof. All right. Dressing disruptions. Do you guys use iodine, alcohol, or chlorhexidine? Which chemical do you use? Alcohol? No iodine? Sometimes? Chlorhexidine? I'm not sure about iodine, but alcohol and chlorhexidine, when it's on the skin wet for too long, what happens to the skin? If I keep it wet. Let's say I keep it wet for 5 minutes. What happens to the skin? It burns. Not pain, literal burning. Chemical, do you know the difference between chemical burn and radiation burn? Like radiation's heat touching my skin and burns. Chemical burn is that the chemical reaction is killing the cells. So the chlorhexidine, the alcohol, will kill the cells and start burning the cells when it's wet for too long. Okay, hold on. If that chemical is so dangerous, why are we using it? It's because it's not designed to be wet for 5 minutes. It's designed to be dry within 2 minutes, 1 minute, 30 seconds. So that's why before we put the tape on, before we put the dressing, we need to make it dry. We need to wait until it's dry. That's very important. Also, the disruption of the dressing is a key factor of infection. Has anyone seen this at their hospital? Does it look familiar, that internal jugular catheter? I know we don't like to, but do you see it sometimes? When it's here, anybody deal with hemodialysis catheters? No, okay, perfect. So you guys don't have to deal with this as much. This is not going to prevent infection. Is the dressing on the patient? Yes or no? Is there a dressing? Yes. Good, there's a dressing. Is there sutures? Is there a securement device? Yes, there's a securement device. Is there an antimicrobial disc? Yes, there's a disc. Good, who cares? Everything is there. What does it matter? This is not going to, even though everything required to prevent an infection is there, it does not mean it's going to stop an infection. What about this one? Is there a dressing? Yes. Is there a disc? Yes. That's chlorhexidine disc. Are there sutures or securement device? Yes. Everything required, the equipment needed to prevent infection is all there, but this is definitely not going to stop an infection. What about this one? For nurses who change the dressing, is this easier or is this easier? Is this IV easier or is this IV easier? Which one's easy to? The second one. Why? It's flat. Yes. There's no range of motion. In the neck, because of this, it's going to start tearing. You know this. We know this. We know it's not going to work very well. If it's here, we know that this is better. However, they keep putting it in like this. Whose fault is it that the patient got an infection, or let's not even talk about infection. Whose fault is it that the dressing is not maintained? Huh? What did she say?
It's not raised.
It's not raised? Okay. Whose fault, who's responsible? The nurses are responsible. You are responsible. I am responsible. Is the janitor responsible for this? Is the photographer responsible for this? Is the dog no. The nurses are responsible for the dressing. So when the patient gets an infection, it was our fault. At the end. Whose fault is it at the beginning? Oh, you were so fast to say doctor. Yes, it is the physician's fault because they put it in. Physician, nurse, RT, I don't care who put it in. It's whoever put it in, that's their fault that led the team to failure. So it is not just nurses. It is not just doctor. It's the whole team that failed the patient. The patient didn't ask for this. They didn't say, hey, I only want half of it on there. Take off the rest. It's okay. I don't need all of it. No. We did this to the patient. Now, the reason why I bring this up is because it's difficult to hear, but it's important for us to take responsibility. Because if we say, no, it's the doctor's fault, we're not going to change anything. If the doctors say, no, it's the nurse's fault, they're not going to change anything. So this is why I need you guys to understand. And so I have been speaking with physicians this past week about this issue. And they've been very receptive. They're hearing it. They said, okay, that is better. Let's figure out how to do that. So they're listening. They're trying to help now that we know there's a solution. But as I'm blaming the physicians and giving them the responsibility, and even for me, because I put them in too, I'm also giving you the responsibility as well. Who's flushing the line? The patient, maybe sometimes. Right, it's us. Who's putting in the IV? Maybe the doctors, but us. So we also need to take responsibility for things that we can do better. So I want you to understand, we're all responsible. No one's to blame. Forgive yourself, forgive each other. Let's do better. Okay? All right. So going into letting the skin dry, these are all the different methods you can use to reduce the dressing disruption. Now, I know I think some of you are taking notes, maybe sending letters to friends, but the PowerPoint, if you want it, Linda will have a copy. Just email her for the PowerPoint. You will have this exact presentation. Okay, so you can read it later, look at the studies later. So you will have this copy. I'm not going to hide it from you. I'm not going to keep it from you. Okay, so infection control. How many of you changed dressings for central line dressing again and PICC lines? Nobody? But sometimes, right? Sometimes you change it? Okay. How many of you wear a mask when you change that central line? No? Ooh, no, it's okay. Tell the truth. You have to tell the truth. The truth is the key to success. Okay. What is this? Is that glitter? Is that a party? It's a bacteria party. Look at what happens when they're talking. I'm so sorry. This whole time, I've been spitting on your face. This is what happens when we breathe and we talk. That's why during COVID, we had that 1 meter rule, right? Was it 1 meter, 2 meters, 3 meters? 2 meters, yeah, we had that 2 meter rule. So this is happening all the time. When you have dinner with your family, I was having dinner with Linda one time and I was like, hey, we're eating each other's spit. This is what happens. So when you change the dressing, it's going to be important that you wear a mask. How many of you wear a mask when you put in the IV? Don't answer that. Okay. How many of you, okay, let's take it another step further. How many of you wear a mask when you're going to flush? How many of you wear a mask when you're going to put in the medication? Right? So what's worse? No mask for dressing change or no mask during injection. Interesting, right? Now, trust me when I say, you do not hate masks more than me. I hate masks. When I was working in the ER, in the emergency room, patient had tuberculosis, airborne precaution, negative pressure room, everything. Patient had meningitis. Man, whatever. I don't need a mask. I've got a strong immune system. I'm okay. Even during COVID, I never got sick when working in the emergency room, and I never wore a mask. I was like, I don't need it. I'm good. But what I didn't realize, it's not for me. It's for the patient. It's not to protect me, it's to protect the patient. So I want you to think about this, okay? Now, this is, of course, infection control. It's going to be a big problem. Now let's talk about pressure ulcers. Anybody have pressure ulcers with sensitive skin? Older patients, maybe?
Here we have a picture.
This is the solution. Just put gauze underneath it. Just put some padding, sterile. That's it.
Real quick.
Pretty simple. All right, catheter reflux. We know when the blood sits still, does it clot or is it good? It clots when it slows down. Did you know that blood is in your catheter a lot? Blood reflux, clamping sequence. Do you guys know your tubing has a clamp? It has a close. Where is it? Let me grab one. Do you guys see this thing? Where you clamp it? When do you clamp it? Before you clamp and then remove, or do you remove and then clamp? Before. Okay, for which one? Did you know that there are different types of needleless connectors? One, you must do it before disconnecting, and one, you must do it after connecting. And if you don't, you're going to have problems with the device.
A lot of you have probably seen this. Wow, look at that reflux.
Did you see
We're going to sit
that negative pressure?
flush one more time just to be sure. Okay, now I want you to keep your eye here while you watch me disconnect. This is going to be the key part, right? Most people do this. They take the hub off. They take the hub off.
Look at what happens when we don't clamp and we remove it improperly.
And look what happens. Look at all that reflux back in. And then we...
That's how much blood is sitting inside of our catheters.
Now here's the next one.
Okay? So when we don't clamp properly or at all, because I didn't believe it. Because I can't see it. I can't see the blood. If I don't see the blood, it's not happening. Until someone showed me that model, I was like, oh, I'm sorry. Did anybody have to change the needleless connector every 7 days? Right? Why is it so hard sometimes? You're like, is it easy all the time or sometimes it's very hard? Very hard. And so you have to get like a tool to open it, right? So this is what's happening.
With the majority of why your catheter needleless connectors are stuck. Have you ever had one of these stuck before? Where you're like, I can't pull it out. I need reconnecting, disconnecting.
Where am I holding it?
While holding it here. At the hub of the catheter and not the needleless connector.
You have to hold it by the needleless connector.
Make a mark.
This is why it's getting too tight.
That mark is moving. And I'm going to show you how much we're torquing, causing these needleless connectors to get stuck. This is our fault. We're doing it wrong. So if I hold it by here, this is what's going to happen.
So even how you hold during connection, disconnection makes a difference.
Okay, that's one time. This is flush number 2. I lost my mark. Okay, let's add another mark. This is going to be mark number 2. All right, cool. Flush number 3. Flush number 4. That thing is, look how much, we almost turned it 180.
So that's going to get in so tight that you're not going to be able to take it out. So that's something that we're doing. All right, so portacath.
Yeah, portacath predstavljam.
Okay, so portacath, whenever you remove the needle, there's a little bit of a reflux because the septum moves. And so you must flush while removing. So if I don't see a little bit of medicine, I didn't do it right. So you have to see a little bit of liquid coming out. That's when it's good. All right. So also port has a direction for flushing. All right. So Linda's going to talk about the different workstations, and we're going to actually get hands-on and do some real practice today. Thank you for your attention.